external examiners today. We have Dr. Gauri Shankar from Professor and HOD of ENT, Government Medical College, Stanley Medical College, Chennai. Welcome, Dr. Gauri Shankar, sir.
Thank you very much, sir.
And the other external examiner is Dr. Suresh Pillai, Professor of ENT, Kasturba Medical College, Manipal. Welcome, Suresh Kumar, sir. Suresh Pillai, sir.
Thank you, Reggie.
Oh. And the presenter today will be Dr. Jennifer, postgraduate student from Dr. Somerville Memorial CSA Medical College. And myself and Dr. Sajidlal will be the internal examiners. Can we start? Suresh Pillai, sir, can I ask the PD to present?
Yeah.
Yes, sir, please.
Yes,
Yeah.
Jennifer,
Okay.
can you please? Yeah.
Yes.
Okay.
Hello. Good evening, sir. I'm Dr. Jennifer. Thank you so much for the opportunity, first of all. And my presentation for today is glottic malignancy. Mr. Johnson, 72-year-old male, a quarry worker, hailing from Parashala, presented with complaints of change in voice for 2 months. History of presenting illness. Patient was apparently normal 2 months back when he developed change in voice, which was insidious in onset, persistent, and gradually progressive in nature. He had no history of pain while swallowing liquids or solids, no history of difficulty in breathing or swallowing, no history of cough while swallowing liquid or solids, no history of any head and neck trauma, no history of any blood-stained sputum or hemoptysis, no history of headaches, nasal discharge, cough, or throat pain, no history of any weakness of limbs or facial weakness or drooling, no history of overstraining or overuse of voice, no history of heartburn, no any ear or nose symptoms.
What was his change in the voice? You said he has history of change in the voice. What was the nature of the change?
It was hoarseness of voice. Hoarseness of voice was his complaint. There was a little roughness in this voice. That was his complaint.
For 2 months?
Yes, for 2 months, yes.
Okay, go on to the history of presenting.
Okay. Past history. He's a known case of systemic hypertension on antihypertensives since 5 years. No history of type 2 diabetes mellitus, pulmonary tuberculosis, coronary artery disease, bronchial asthma, seizure disorders. No history of any ear or nose or throat surgeries in the past. His personal history, mixed Indian diet with normal appetite, no sleep disturbances, normal bowel and bladder habits, no history of alcohol or smoking or any other drug addictions, no known drug or food allergies. Family history, he was married and has 2 children, no similar illnesses in the family or no other significant family history, belongs to lower socioeconomic class, no history of overcrowding.
Any history of tuberculosis in your family?
No, sir.
No, did you ask the patient?
Yes, I did, sir.
Okay, there is no history of tuberculosis in his family. Okay, go ahead.
Okay.
From this history,
yes,
you have not gone into the examination yet. What are the things crossing your mind in terms of diagnosis? This much of history.
This much of history, keeping in mind of his age and his profession. Malignancy is one of the things that crossed my mind. Apart from that, it can be a cyst or a vocal nodule or something of that sort also. But then we cannot conclude a diagnosis unless a further examinations has been done.
Can you tell us something about that hoarseness? Can you describe that hoarseness a little bit more?
Describe the hoarseness. So the hoarseness was what he and his family members complained was it was a roughness in the voice, which was suddenly started, but then it started increasing and increasing. The patient was not able to phonate properly.
Was there a diurnal variation?
No, there was no diurnal variation. No.
Why is that important?
Because, for example, if it is laryngitis, which is caused by gastroesophageal reflux disease, there will be a diurnal variation in the voice.
does gastroesophageal reflux disease cause laryngeal symptoms?
Yes, it is. No, sorry, I meant laryngeo, LPRD, sorry, laryngopharyngeal.
What is the difference between LPR and GERD?
GERD is gastroesophageal distress, which happens in the lower abdomen, and the patient will complain of epigastric pain and burning
GERD is
sensation.
in lower abdomen.
Yes. No. Yeah. GERD will be a lower abdominal pain sensation. Yes.
Not lower. Epigastric pain.
You want
Sorry,
to
sir?
you want to rephrase that, Jennifer? When you get GERD, where do you get the symptoms?
Epigastric pain.
Epigastric. It's
Yes, it's the
heartburn,
upper.
right? Lower
Yes, it's the
esophageal,
heartburn, yes.
burning sensation.
Sorry. Yes, sir.
Yeah, it's not lower abdomen.
Yeah, it's upper esophageal.
Okay, so
It's
you
upper
wanted
abdomen,
to,
not lower abdomen. It's
Mm.
upper abdomen. Okay.
Upper abdomen. Yes, sir.
Only appendicitis things you will get lower abdomen pain, not a GERD.
Sorry, sir.
GERD you will
Yes,
get
sir.
a heartburn. Okay.
Yes, sir.
okay, so you wanted to rule out by diurnal variation whether it could be LPR.
Yes, LPRD. Yes, sir.
Anything else you want to rule out by diurnal variation other than LPR?
Diurnal variation.
Okay, other than hoarseness of voice, what
Hmm.
other types of voice will you get if you have some lesion on the larynx, other than hoarseness?
Lesion in the larynx.
Yeah, if there is a lesion in the larynx, other than it doesn't have to be on the vocal cord.
If it's there will be high-pitched voice for TB laryngitis.
No. Not in the vocal cord. Supraglottic malignancy, what type of voice you get, sir? That's what sir is asking.
Yeah.
Not in the vocal cord. Supraglottis.
Sajilal knows my questions. Huh? Yeah.
What type of voice you get in supraglottic malignancy?
Hot potato voice.
Yeah. What is that hot potato voice?
Hot potato voice is hot potato voice. It mainly happens when there is a peritonsillar abscess.
Only in peritonsil abscess you get a hot potato voice?
No, one of the causes of hot potato voice is
What causes it? It's a obstructive lesion, a mass there, right?
Yes, sir.
Yeah, so you can have a huge supraglottic tumor. Yeah, causing a hot potato voice. So it doesn't have to be necessarily hoarseness of voice for malignancy.
Yes, sir.
You understood, right? You
Yes,
didn't
yes,
spend
sir.
too much time on that change in voice, which is an important feature.
Okay, sir.
That is why we had to go back to that.
All right, sir.
What is the cover body theory of phonation? Cover body theory. Maybe a short note for you.
Yeah. If you tell the layers of vocal cord, then you can. If you know the layers of vocal cord, then you know the cover body theory. Correct, sir?
Yeah, correct.
Can you tell the layers, Jennifer?
Yes, sir. The layers of vocal cord, first is the epithelium, and then it's the lamina propria, which is divided into superficial, middle, and deep. And then is the body, which is consisting of the vocalis.
So now you said what is cover?
The cover is the epithelium.
Epithelium only.
Epithelium and the lamina propria, which is the Rhenke
What is
space.
the
Superficial layer of the lamina propria is also called Rhenke space.
okay? Those are the cover.
Yes, sir.
Then transition.
Transition is the middle and the deep layer of the lamina propria.
What is the intermediate and deep layer form of the
Vocal
lamina?
ligament. Vocal ligament.
Vocal ligament. Who described this cover body theory? Famous person. Died only recently.
Sorry.
You know, a Japanese name. Do you know?
No, sir.
Okay.
Sorry.
All right. Now you said there was no history of smoking, right?
Yes, sir. Excuse me, sir.
There was no history of smoking,
No, no, there was no history of smoking. Yes, sir.
but you're thinking of malignancy.
Yes, sir.
Did you ask the occupational history?
Yes, sir. He was a quarry
What-
worker.
So what do
What
you think
worker?
would be the etiology?
It's the quarry mining dust can be one of the reasons.
What is the main cause for melangial malignancy etiology?
Smoking
What is the
and
one
alcohol.
thing that is implicated?
Smoking and alcohol.
Smoking, that is the main thing. 95% of cases usually get history of smoking. What is
Yes,
it? What is it in smoke that causes malignancy? How many carcinogenic items are there in cigarette smoke?
It's benzyl pyrethan.
Okay, benzene.
Benzene.
You have it. Then what are the other ingredients which are carcinogenic? Cigarette smoke,
Nitrosamines.
nitrosamines.
Then
What do you mean by a pack year? Have you heard of the term pack year?
yes, sir. Yes, sir. Yes,
What
sir.
is a pack year?
A pack year is the number of cigarettes a person smokes divided by 20 into the number of years smoked.
Divided by 20. Why 20?
Number of, because in one pack there'll be 20 cigarettes approximately.
Okay, if I say the pack years is 20, what does that mean?
If you say the pack year is 20, that means the
Yeah.
patient has smoked.
Use your formula.
Yeah, so I'm trying to do it.
So pack year is 20. What does that mean?
It means where the patient smokes one pack of cigarette a day.
One packet per day for 20 years, or you can smoke 2 packets per day for 10 years.
10 years. Yes,
Yeah,
sir.
that is also mean pack years, right?
Pack year. Yes, sir. Yes,
Okay,
sir.
but this patient had no history of smoking.
No history.
Only working in a quarry. How long did he work in a quarry?
He worked in a quarry for around 40 years.
40 years. Okay, what are the other etiological factors for laryngeal malignancy other than smoking, other than quarry?
Alcohol intake.
Why does alcohol produce laryngeal malignancy?
Alcohol is so there are just laryngeal malignancy or sir generally malignancy.
You said laryngeal, we are talking
Yes,
about
sir.
laryngeal malignancy, right? You said
Yes, sir.
alcohol is one of the risk factors.
Yes, sir.
How?
So there are there are 2-3 points to it, sir. So alcohol is a solvent that causes irritation of the mucous membranes, which causes increased permeability of the adjacent tobacco smokes and carcinogens. So that is one point. Then sorry, sir. Excuse me.
No, go ahead.
Okay, sorry, something's wrong with my laptop. Okay, yes, sir. That is one of the point. Second one was so alcohol upregulates cytochrome 450, which converts the procarcinogens into carcinogenous materials. Then the next immediate intermediate of the alcohol is aldehydes, which itself is a carcinogen and it causes local irritation. Then it also breaks down. It also DNA repair. Yeah, it actually slows down the DNA repair, so it can cause chromosomal damages also.
Okay, what are the other carcinogenic? What are the other factors for laryngeal malignancy other than smoking, other than alcohol, other than quarry dust?
Other than quarry dust, it can be industrial leather factory, all the occupational related materials. For example, it can be of leather, ship, paper, or asbestos.
Viral etiology.
Yes,
Virus.
human papilloma virus.
Which type?
6 and 8, 16 and 18.
So it's a pre-malignant condition, no?
Yes, sir. Yes, sir.
So what are the types of vocal cord papillomas, you know?
Recurrent laryngeal papillomatosis,
What is that?
Pre-malignant.
which is caused because of HPA 16 and 18, which causes numerous papilloma-like lesions over the vocal cords.
Only vocal cords, huh? What is that called?
The disease, sir?
No. There are two types of papillomas. One is
Yes.
one which age group one will get in which age group, the other will get in which age group. What is that called?
One is one you get it in the younger age group.
What is
which
that called?
Juvenile papillomatosis.
So can you tell something? Is it a pre-malignant condition?
Yes, sir.
Yes, sir.
The ones which is caused in childhood is not this thing pre-malignant
Then you
condition.
tell me which is pre-malignant. Then you tell which is pre-malignant.
The one which causes 18 adult, the one which causes in adult.
Like that, adult papilloma larynx.
Adult
Okay.
papilloma larynx, yes, sir. That is a pre-malignant condition.
That is single. Okay.
Yes, sir.
Okay.
All right. Go ahead. Go ahead with it. Reggie, when do we stop? How much time do we have?
Actually, it is between 7 to 9, sir. 2
7
hours
to
is
9.
there. Yeah.
Okay. All right. Okay. Go ahead.
Okay, moving on to general examination. Patient is conscious and well oriented to time, place, and person. Well nourished and moderately built. No pallor, icterus, cyanosis, clubbing, cervical lymphadenopathy, pitting pedal edema. Vitals, patient was afebrile. Pulse rate was 89 per minute, regular. Blood pressure was 150/90 millimeter mercury.
In general examination, do you do cervical lymphadenopathy or generalized lymphadenopathy?
Generalized lymphadenopathy, sir.
So you just looked at the neck,
Yes.
is it?
No, no, sir.
It's a general examination.
General
right?
examination, yes, sir. Generalized lymphadenopathy, yes, sir.
Okay.
Systemic examination, cardiovascular system, S1, S2 sounds were heard, no added sounds. CNS, no focal neurological deficit. Respiratory bilateral air entry was equal. Normal vesicular breath sounds was heard. No additional sound.
In CNS examination, did you check the cranial nerves?
Yes, sir.
Which cranial nerve is important in vocal cord?
Cranial nerve 10, vagus.
Okay. So it is normal. Cranial nerve examination is normal.
Yes, sir. Yes, sir.
All the cranial nerve. So you're supposed to tell that, no?
Yes.
Only I am. Okay, cranial nerve examination is normal. Okay.
Yes, sir.
Then.
Yes, sir. Gastrointestinal system, parabdominal was soft and non-tender. Then moving on to local examination. Local examination. First is oral cavity. Mouth opening was adequate. Lips were normal. Angle of mouth.
What do you mean by adequate mouth opening?
More than 3 finger breadth opening of mouth. The patient could open.
Whose fingers? The patient's or the examiner's?
The examiners.
So the examiner can be big, so only 2 fingers can go in, or the examiner can be small. Can you be more objective regarding mouth opening? I know you can do a finger examination also, but if you were to do it objectively, how will you state this? What is normal?
It's the, sir, are you asking about the Malampatti grading?
No. Mouth opening, incisor to incisor distance in an adult male. That is objective, not fingers. What is a normal incisor to upper incisor to lower incisor in terms of millimeters?
In 30 millimeter.
30, more than 35 in an adult male.
Yes, sir. 35 in an adult.
Okay.
Yes, sir.
All right. Mouth opening is adequate. Go ahead.
Lips normal. Angle of mouth normal. Buccal mucosa normal, gums and floor of mouth
Can you
normal.
name some lesions? You said lips are normal. So upper lip is normal, lower lip is normal, right?
Yes, sir.
So what are the lesions you can see in the upper lip? Can you name some lesions that can occur in the upper lip?
Upper lip lesions can be sir, unrelated to malignancy, right? Just general
Yeah,
reasons.
unrelated to malignancy. some lesions.
Malignancy. What malignancy you get in the upper lip?
Basal cell carcinoma.
Yes.
Basal cell carcinoma.
Basal cell carcinoma. What is the other name for this basal cell carcinoma?
Rodent ulcer.
Rodent ulcer. How can you tell this ulcer is basal cell carcinoma? Are there any peculiar features?
Yes, it's the color of the lesion will be a dark brown, and it will have distinct margins. And
What type of edge you get?
yes, sorry, sir.
Edge.
Irregular margin.
No. Rodent ulcer. What are the other lesions you can get in the lips? Any vitamin deficiency lesions you can get? Lips, angle of the mouth. Vitamin deficiency.
Yes, sir. Yes. Angular cheilitis.
Angular?
Cheilitis.
In which vitamin deficiency will you get that?
Vitamin B12.
No.
Not B12. B12 you will get B fetal.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
It is called angular stomatitis or
Angular
cheilitis. Okay.
Yes, sir. Yes, sir.
Do you know what is the difference between a margin of an ulcer and the edge of an ulcer?
What is margin? What is edge?
I don't know the definition, sir.
What type of edge you get in squamous cell carcinoma? What type of edge you get in tuberculosis?
These are basic things you should know.
Yes, sir.
Tuberculosis, what type of edge? Squamous cell carcinoma, what type of edge you should know?
So it's undermined edge
In
TB.
TB. And what about the edge in squamous cell carcinoma? Inverted or everted?
Everted.
Then sir asked, what is margin? What do you mean by margin?
You know or don't know?
No, I don't know, sir. Sorry.
Then you tell that.
Yes, sir.
Do you know what is the difference between the floor of an ulcer and the base of an ulcer? For malignancies, you need to know that. Especially in oral cancers, squamous cell carcinoma, you should know what is the floor of an ulcer and the base of an ulcer.
What will happen to the base in a case of malignancy?
Sure.
What will happen to the base in a case of malignancy? When you palpate, how you feel?
Indurated, hard.
Okay.
Yeah, that's what you tell boldly.
The base of the ulcer for a squamous cell carcinoma will be hard, and you can actually, when we palpate, you feel the induration.
Why it is indurated?
Because of hypertrophy of the.
No. Why it is indurated? Because of deeper invasion. It is not superficial, no?
Yes, sir. Deep palpation.
So what is the base of the ulcer? Base you told, okay.
Floor.
Flow.
What is a floor then? You've been talking about the base, and what do you mean by a floor?
The floor is the area which is exposed and we can see.
Yeah, what you're seeing is a floor. What the floor rests on is the base.
Base.
Very important to distinguish, okay?
Yes, sir.
Yeah, okay.
In inflammatory ulcer, what type of base you get?
Inflammatory base is soft.
There will not be any indudation, okay? In malignant ulcer,
indudation.
there will be indudation.
Yes, sir.
And it inflammatory also, it is painful when you palpate. Here it is not painful, it feels bleed from the surface. Okay, when you palpate it. Okay,
Okay,
sure.
sir.
Okay.
Hmm. Shall I go forward, sir?
Yeah, go ahead, go ahead.
Gums and floor of the mouth normal. Gingival labial sulcus and gingival buccal sulcus normal. Anterior two-third of tongue normal. Retromolar tiger normal. Teeth partly edentulous. Anterior pillar normal. Tonsils no tonsillar hypertrophy.
What is the
Posterior-
anatomy of retromolar trigon?
The base is formed by the alveolar process. And by the medially is formed by the maxillary crest.
Maxillary crest.
Maxillary.
Sorry.
Maxilla is above, no?
Yes, sir. It's maxillary. Mandibular crest. Sorry, ramus of the mandible. It's formed by the
Okay.
yes.
Okay, go ahead, go ahead.
Posterior fillar normal, soft palate normal, uvula central, posterior pharyngeal wall.
What is the division line between the oral cavity and the oropharynx? Superiorly, laterally, inferiorly?
Superiorly, laterally, and inferiorly. Inferiorly by the base of tongue.
Base of tongue is a huge area, no?
So the divide in demarcation, you have to tell.
Demarcation. Which
What is
divide the
above?
anterior which divides the anterior two-third from the posterior third? What divides?
The circumvallate papillae.
What is the lateral boundary? Above. Soft palate is oropharynx or oral cavity?
Soft palate is oropharynx.
Now you tell me above what it could be.
Soft palate.
Not soft palate. What is the demarcation? Hard palate is oral cavity or oropharynx? Hello?
Yes, sir. Sir, I don't know, sir.
Hard palate is oral cavity or oropharynx?
Hard palate is oral cavity.
Huh?
Oral cavity.
Then what is the demarcation?
The junction between the soft palate and the
Yeah,
hard.
that's it. Then laterally?
Laterally by the anterior pillar of tonsils.
Yeah.
Yes, sir.
Anterior pillar. So you see, you have to know, you have to distinguish oral cavity lesions from oropharynx. There'll be tumors extending. You have to know these boundaries, huh?
Yes, sir.
Okay, go ahead.
Examination of neck. Inspection.
Well, you finish the oropharynx?
No, oropharynx, after oropharynx, what you supposed to tell? You jumped into neck.
Yeah, indirect, both indirect.
Indirect
Class.
larynx. Sorry. Indirect laryngoscopy. Base of tongue normal, vallicula normal, median and lateral glossoepiglottic force normal.
What is vallicula?
Vallicula is the it's the space in front of the epiglottis
Between what and what folds?
between which is glossoepiglottic folds.
Between the medial and lateral glossoepiglottic fold. Okay, proceed.
Epiglottis normal, bilateral aryepiglottic folds normal, bilateral arytenoids normal.
You describe the lesion first.
Okay. Vocal coslum, ulcerative, ulcerar proliferative growth in the posterior 1/3 of right vocal cord. Margins of the surface were irregular. It measured around 1.5 to 0.5 centimeter.
What is your pyriform fossa? What did you say? Minimal pooling
Yeah, minimal pulling, yes, sir.
on the right side.
Yes, sir.
What does that indicate?
That there is a lesion in the there's a lesion in the vocal cord or in the glottis that is
This is
No.
pooling
Sir
of-
is asking what does pooling of saliva in pyriform sinus indicate? What is that sign called?
Jackson sign.
Which condition will you get that? Will you get in a laryngeal malignancy?
No. Posterior cricoid malignancy. Post-cricoid malignancy.
Sir is asking how will you explain in a vocal cord malignancy, how will you explain this pooling of saliva? Sir is asking. Why did you say pooling of saliva?
Because when we did an ideal, there was actually pooling of saliva in the right PFS.
But was it persisting?
But it was not persisting. Once the patient forcibly evacuated some sputum, there was no more pooling left. So just wrote it there.
See, pooling of saliva means obstruction further down. It could be in the apex of the pyriform fossa, cricopharynx. But if it is in the cricopharynx, it should be bilateral. You didn't get it on both sides, right?
No, we didn't get it.
Second thing could be due to decreased phonation of the vocal cord on that side. You
Okay,
understood, right? So you have to explain all these signs. If you find a sign, you have to explain it.
yes.
This you said is, what is it? Jackson sign.
Jackson sign, yes.
Who's it named after? Jackson sign. Very famous person in ENT.
Chevalier Jackson.
Chevalier Jackson. Chevalier Jackson, okay? All right. Okay, go ahead.
Can I go to the next slide, sir?
Yeah.
This is the video of the 70-degree endoscopy which we did.
Wait, did you mention the mobility? Go back.
No, I did not.
Why didn't you mention? Is it important to know whether it is mobile or not?
Yes, sir, it is very important.
Is it mobile or not? Vocal
It is
cord.
mobile. Bilateral vocal cord was mobile. Yes, sir.
Was it restricted mobility?
No, there was no restricted mobility.
Why is it important to note the mobility of the vocal cord? Now you'll get a lot of questions on this because you missed this.
Because, yes, sir.
Why is it important to know the mobility?
To know the staging of the disease?
Yeah, it affects the staging.
Yes, sir.
So limited mobility, restricted mobility, what stage is it?
T2.
When it is fixed,
T3.
when it is not moving, what stage is it?
T3.
T3.
Yes, sir.
What are the reasons why the vocal cord does not move in malignancy? What are the reasons for T3 stage in malignancy?
Mass effect.
No,
Yeah.
T3, T3.
Go on.
Sir is asking T3, why you are getting? Hello?
Yes, sir.
What are the causes of fixity of vocal cord in malignancy? You tell. What nerve is involved? What muscle is involved? What joint could be get involved? We told mass effect one. Then other causes. Involvement of which nerve?
Is she there? I think,
No, no,
yeah.
sir, I'm here. I'm trying to think, sir, because there are 2-3 points I cannot recall it now. Sorry.
This
this
should
is very
recall.
important.
Very important.
Yes, yes, sir, I know.
Don't get tense. You are answering. I gave you a clue. What nerve is involved? What muscle is involved? What joint is involved?
Sir, one is mass effect, then is the thyroarytenoid muscle involvement,
Infiltration into the okay. Then
then arytenoid cartilage involvement,
which cartilage?
arytenoids,
Trichoarytenoid joint fixation can occur because then involvement of recurrent laryngeal nerve.
enough nerve involvement.
You forgot the nerve. Without that, what is the use of proceeding?
Yes, yes. Sorry, sir.
So both cords mobile.
Yes.
Okay. All right. Go ahead.
This is the 70-degree endoscopy video, sir.
Can you describe this as you're playing it?
Yes, sir. So the 70-degree endoscopy was passed, and as you can see, there is a right PFS, there is a pooling is noted. Left there is no pooling, and the vocal cord, there is in the posterior 1/3 there is a lesion, which is not extending to the midline, which is not crossing the midline, and both the vocal cords are.
How will you explain the lesion? How will you explain the lesion? What type of lesion it is?
It's an ulcer-proliferative lesion.
Okay. Okay.
Can you go back to the vocal cord? Let me see it.
Oh,
No, the other one, the video.
video, yes, sir.
Okay, go back to the vocal cord. Yeah, then stop. Yeah, just stop there for 1 minute. Yeah, go back. Yeah.
Okay.
What are you seeing?
Zoom
Describe
it.
the right vocal cord. Just describe it again.
No, actually, behind it looks like there is a lesion in the right vocal cord also, but it's not there because it was all mucus and saliva. Once the patient actually forcefully spat out the sputum, there was only the vocal cord lesion in the right.
Wait, can you do that? Can you play
Yes,
that
sir.
again, please? Yeah.
1 second.
Just play the whole video.
Yes, sir. 1 second.
You said the lesion was in the right side or
Right.
left side?
Right side, sir.
Right side, posteriorly, right?
Yes, sir.
But is there any irregularity on the left side?
Yeah, no, there is, even we thought so, but then once the patient spat out, there was no irregularity. It was actually normal.
So what was there to cause that appearance?
It was just maybe saliva or sputum or.
So is the patient aspirating? Why
No.
should there be saliva there? There shouldn't be saliva in a normal condition. And you can see the pooling of saliva on the right side. Does he have dysphagia?
No.
He's taking normal diet?
Yes, sir. He is taking normal diet. Yes, sir.
But he's aspirating here, right? In this? Okay, how will you confirm whether he's able to swallow, whether he's aspirating? What test would you like to do?
Hmm,
What is the test that you would prescribe in a patient like this?
a swallowing assessment. Is that what you're asking, sir?
What is that term called? What is fees? Fees. What is it? How do you do it? What is it use? Whether it's useful in this condition?
If-
What does it stand for? Fees.
Sorry, sir.
Don't know.
Please, you don't know.
It's a very important part, especially in patients where you're suspecting this kind of aspiration.
Normally, when we have a patient suspecting aspiration, we do a nasopharyngeal laryngoscope. Is that?
Let us read
Fiber
about
optic.
It's
What is the full form? This is a short note for you. This would be a question for your university exam.
yes, sir. Fiber optic endoscopic evaluation of swallowing.
So how do you do it?
We
What are the things you look for?
do you want to do I have to explain the procedure? How do I do it?
Yes.
Yes, okay. So the patient is comfortably seated, and then decongestant and anesthetizing nose drops are instilled, and then the fiber optic the scope is passed through the one nasal cavity, and then it is slowly advanced below the base of tongue. Below it goes into the larynx. I mean, it goes into the larynx, and then we can see the pooling and the this thing. We can see all the
No.
laryngeal parts, and then you ask the patient. The patient is asked to swallow. First, the patient is asked to make sounds to see the mobility of the vocal cord, and then we give them a small amount of water or any liquid, and then ask the patient to swallow, and then we look for the pooling or the trickling of the liquid into the trachea.
So you give liquids, semi-solid, and solid, 3 items.
Okay.
Correct?
Yes, sir.
Start with liquid. So when you give these food items, what are the 2 things you're looking for?
One, we look into the trickling of these food particles or the liquid into the trachea.
Trickling. When you give liquid, what will happen? When you give water, what will happen to the patient?
If there is
If there is aspiration, what will happen?
If there is aspiration, the patient will start coughing.
So you look for aspiration and
Cough.
penetration.
Penetration, yes, sir, penetration.
So what's the difference? What is penetration? What do you mean by aspiration?
Penetration. Aspiration is when the materials pass through the through the vocal cord into the trachea. That is called penetration.
That is aspiration. Into the
No, sir, I don't know the difference. Sir.
You know or don't know? If you don't know, you tell don't know.
I don't know, sir.
Okay. So in this case, where you're having, look at that, you play that video again, it's very significant. There is pooling of saliva. Whether there is malignancy there or not, we don't know. And then it is trickling onto the vocal cord, right? But the cords are mobile, isn't it?
Yes, sir.
Do you think there is any tumor that has spread into the paraglottic space?
No, because once the patient actually spat out, there was no more pooling or no more trickling.
What is a paraglottic space?
So, sir.
no, are you suspecting any paraglottic involvement? Yes or no?
No.
Shall is asking. Huh?
No.
No. Why you are saying? You are saying there is no paraglottic involvement.
Paraglottic involvement.
there is a paraglottic, if there was a paraglottic involvement, what would be the finding? Will the vocal cord be mobile?
No.
What are the boundaries of paraglottic space?
Paraglottic space, anterolaterally, it is bounded by the thyroid cartilage. Inferior medially, it is by the conus elasticus, and then medially, the ventricle and the quadrangular membrane. Hello?
What are the boundaries of pre-epiglottic space?
Pre-epiglottic space is anteriorly by the thyroid anterior by the thyroid cartilage and the thyroid membrane. Then it is continuous with the paraepiglottic place laterally, and then posteriorly by the infrahyoid epiglottis and the quadrangular membrane.
And above by the
The ligament, the thyroepiglottic ligament.
Higher epiglottic. Higher epiglottic.
Higher epiglottic ligament. Yes, sir.
Okay, the
Gauri
area.
Shankar, sir.
And sir?
Hello?
Sorry, sir, I didn't get the question.
No.
Okay, ariepiglottic fold, is it widened? Is it normal in this case on the right side?
It's normal.
Just play that again. Yeah.
Yes, sir. Thank you, sir. It's normal.
What is other epiglottic fold called? What is that area called? What is that area called? Other epiglottic fold.
I cannot recall, sir.
What zone? What is that zone? Some zone. What
Marginal
zone? Huh?
Marginal zone?
Why marginal zone?
Because of the
Tumor
transition
involved.
of the epithelium.
Yeah, it's a marginal zone. Why it is called marginal zone?
Because of the transition of the respiratory epithelium into the squamous epithelium.
What are you talking? I don't.
Sorry.
No. Why it is called marginal zone? Because it is closely proximity to what? It is closely related to what? Other epiglottic fold.
Right.
So what bound? Wall of medial wall of the pyriform
Yes,
sinus.
sir.
So tumor involving the marginal zone is very aggressive because it is closely proximity to the hypopharynx. No.
Yes, sir.
That's why sir is interested in other epiglottic fold. Okay.
Sure, sir. Okay, sir.
Is it involved or not?
No, it's not.
Not involved. Okay, go ahead then.
Go ahead.
Yes, sir.
Dr. Jennifer?
Yes, sir.
Yeah, this is Dr. Gauri Shankar from Stanley, Chennai.
Good evening, sir.
Nice attempt, nice presentation. Just few corrections regarding history.
Yes,
This is
sir.
a larynx case, a long case. And history, I would suggest you to add on few things about dysphagia. You added upon pain on swallowing, the first slide.
Yes,
So
sir.
I would suggest you to comment about the difficulty in swallowing that should have been mentioned. One correction. And one more thing is in the examination of oral cavity, you should segregate in oropharynx and oral cavity. So you have clubbed everything in both.
Yes, sir. Yes.
That's one thing. And regarding your ideal findings, can you go back to ideal findings slide?
Sir.
Yeah, here one small correction is measuring. Is it possible with interlaryngeal mirror?
It's
You have
not.
mentioned 1.5 into 0.5. So I
Yes,
think
sir.
you can avoid such things. It is possible. We don't usually measure with interlaryngeal. Of ideal, what is Killian's method, reverse Killian's method? There are various types of doing ideal. Examiner sitting and patient sitting, examiner standing, and examiner at a lower level. Okay, so reverse Killian's method are there. So just have an idea about ideal mirror also. Nice presentations. And
Yes.
Suresh Pillai sir's questions are really amazing. I hope sir remembers me.
Yeah, I remember you, sir. Yeah, of course.
Very
Yeah.
nice.
I
And,
was waiting for you to jump in.
No, sir. I'm just listening to all the questions. It is really nice discussion.
Yeah.
Just please go ahead, sir.
No,
And,
your thoughts are very useful. Please jump in whenever you
Yes, sir.
feel
Yes,
it.
sir.
Yeah, yes, sir.
Nice. Please go ahead, Dr. Jennifer.
Yeah. Just yeah, go ahead.
So
Just from the history point of view, you know the first person to have seen his own vocal cords? I'm a history buff. I like history of medicine. So I ask a lot of history. I have a club, history of medicine club here in Manipal also.
Who is the father of laryngology? Sir is asking who is the father of laryngology.
Yeah.
I know all Suresh Pillai's questions. I know.
Yeah.
It is Azarika sir's famous favorite question.
Yeah. Who was the first person to see his own vocal cords? Any idea how he saw the vocal cords? No idea.
no, sir.
I'm trying to get you people to read beyond your ENT textbook, a little bit of history. Chevalier Jackson, he's famous for so many things.
Yes.
Grano, the person who
Okay.
mentioned the layers of the vocal cord, he was trying to figure out how the human voice can go to such a high pitch. And he started dissecting the layers of the vocal cord in the laboratory. Hirano, 1974. There's so much of history in all this, all right?
All right, sir.
What is the function of the larynx? What is the main function? Why did nature give you larynx?
Phonation.
Wrong. That is a secondary effect. Man's ingenuity. We were able to phonate with the help of the vocal cord, but the main function, nature's main function is what?
It's larynx is called the watchdog. Lungs.
Why? It is a protective effect, right? It protects the lower airway.
Sphincter.
Yes.
It acts as the sphincter.
Yes. What he said was correct. It acts as a sphincter. That is the main thing. Later, we learned how to make it into a sound generating system, right?
Yes.
Okay. All right. Go ahead.
No. External frame of nose normal. Oh, no. Sorry for that, sir.
Examination. Go to the neck examination.
Neck examination, yes, sir. Neck examination, inspection, skin over the neck was normal. No scars, sinus, dilated veins, trachea was central. Palpation, laryngeal crepitus was present. No thyromegaly, no tenderness, no fullness, no cervical lymphadenopathy. Bilateral carotid pulsations palpable. Percussion, normal resonance over manubrium. Auscultation, no bruits.
What is this laryngeal crepitus you said was positive? What does that mean? Why did you look for it?
Laryngeal crepitus. Because laryngeal crepitus. Laryngeal crepitus is formed when it's formed by a click, which is called the cricovertebral click.
Click.
Cricovertebral. It's a sound which is heard while you move the cricoid over the vertebrae.
Cricovertebral. Only cricovertebral. There are two clicks. Only cricovertebral.
Thyrovertebral and cricovertebral.
Two clicks. So in normal anatomy, the laryngeal crepitus will be present. But if there is any hypopharyngeal malignancy or post-cricoid malignancy, in such cases, the laryngeal crepitus will be absent.
Only
What
in
is that sign called? What is that sign called?
The laryngeal crepitus is called the Muir's crackles, and the absence of laryngeal crepitus is called the Boca sign.
Boca sign, positive or negative?
Positive.
no, only in malignancy. Any other condition you get absent laryngeal crepitus?
Retropharyngeal abscess.
Okay. Okay.
Okay. You didn't find any cervical lymphadenopathy?
No, I didn't. No, sir.
Why there is no lymph nodes?
No palpable lymph nodes.
Oh, why there is no palpable lymph nodes?
How will you explain it? You're thinking of malignancy. You have seen the lesion in the vocal cord. Can you explain why there are no cervical lymph nodes?
It's an early stage of the malignancy.
No, that is
In glottis, your case.
your case.
This is a glottic malignancy, no?
Yes, sir.
So why there is no lymph node? What is the percentage of lymph node metastasis in glottic malignancy?
First stage of lymph node metastasis is
Does the vocal cord have a lymphatic drainage?
no.
No, the answer. Then why can't you answer? Huh?
Yes. Yeah, there is no lymph node drainage. That's why there is no lymph node.
That is the reason in your case. That is the answer sir wanted from you.
And you should know the systematic method of examination of neck node. It is given in Stell and Maran book. Okay. You have to go behind the patient and how to start, where to keep your thumb over the master process and keep the other fingers like a C-shaped over the sternomaster muscle and you palpate. Kindly go through Stell and Maran. It gives wonderful description of how to palpate the neck node in a systematic way.
Okay. Supposing this was a supraglottic lesion, not a glottic lesion, would you expect lymph nodes?
Yes.
Why?
Yes. Because of the lymph node drainage in the upper cervical lymph nodes.
Supraglottic is rich in lymphatics. It drains which level?
Cervical. 2A and 2B.
2A. Okay. 2 and 3.
2 and 3.
Laryngeal malignancies would lead to lymph node metastasis in level 2, 3, 4. Okay? And more in supraglottis because it has rich in lymphatics. What's the percentage, roughly? If you have a huge supraglottic malignancy, what is the percentage of lymph node metastasis? Do you know? Is it equal to glottic? More than glottic?
More than glottic.
So how much more?
How much more?
Almost 60%. You can get lymph node metastasis, right?
Yes, sir, 60%.
What about subglottis, subglottic malignancies? Where will the lymph nodes, where will you look for the lymph nodes if it is subglottic?
Level 6 pretracheal lymph nodes.
What is level 6? What are the boundaries of level 6? Superiorly, inferiorly, laterally. Are you there?
Yes, sir, I'm here.
Yeah. Level 6, all these boundaries you need to know, levels.
Yes, sir.
Who first described all neck levels?
How much it was?
First person.
Memorial Sloan Kettering.
Yeah, who was the person behind it? The paper. It's a landmark paper. It's a landmark paper. We can be proud of him because who is it? Who is one of the authors? Okay, you don't know. Just tell me the boundaries. Level 6 you need to know, especially in laryngeal malignancies.
The level 6 lymph nodes are the pretracheal lymph nodes or the Delphian lymph nodes.
No, the boundaries.
The
Boundary of level 6.
suprasternal notch.
Below?
Suprasternal notch is the lower bound below. Upper is the hyoid bone. And the laterally is the common carotid artery. the carotid sheath.
So in this, you'll find prelaryngeal lymph nodes and paratracheal lymph. That's where you get malignancies if it is a subclotic lesion, right?
Yes, sir.
What is a Delphian node? Have you heard of a Delphian node?
Yes, sir.
How did the name come up? Delphian, Delphi. Where's Delphi?
I don't know, sir.
You don't know. Why is it called Delphian node? Where is it seen?
Level 6.
It's
Lymph
in
node.
level 6, but where will you see? There are prelaryngeal lymph nodes. Prelaryngeal lymph nodes, more commonly seen with T3, T4 lesions. You know your neck levels?
Yes, sir.
What's level 2? Upper boundary, lower boundary?
Level 2.
No, level 2 is between what and what?
Level 2 is upper jugular.
Yeah, between what and what?
So all these things, there are boundaries which you
Yes,
should
sir.
learn. You should know. You can just tell upper jugular, mid jugular, and lower jugular. No, but there are boundaries for all these nodes, which you are supposed to know as a postgraduate. Huh?
Yes, sir.
Which laryngeal malignancy you get bilateral lymph nodes?
I don't know, sir.
Don't know. What are
Tell the
the
midline.
So generally, what are the malignancy? You will get bilateral neck nodes. Starting from nasopharynx, right up to the neck, lower down, you have to tell. What are they? What are the malignancy where you will get bilateral neck nodes? Nasopharyngeal carcinoma, base of tongue lesion, glottic malignancy,
Basic.
thyroid malignancies. Okay.
Yes, sir.
Post-cricoid malignancy, all midline tumors
Yes, sir.
can lead to bilateral neck node. That is important.
Hmm.
What are the normal structures in the neck which can mimic a lymph node? May think it is a lymph node, it could be a normal structure. You know or don't know?
I don't know, sir.
Everything is given in a cell and marrow. Bifurcation of the carotid can mimic a lymph node. Beta horn. Okay.
Yes, sir.
Submandibular salivary gland can mimic a lymph node.
Hmm.
Tail of the parotid can mimic a lymph node. Even though they are normal structures, while palpating, you may feel that it is a lymph node.
Hmm.
So these boundaries of levels of lymph node, you should be thorough. You can't just
Yes.
tell upper 1/3, lower 1/3 of internal jugular vein. There are boundaries. Okay.
Okay, sir.
This, you said there's no tenderness of what? Under palpation, you've written no tenderness, no fullness.
Yes,
Of
yes,
what?
sir. Then tenderness over the thyroid cartilage.
Why did you look for tenderness over the thyroid cartilage?
Because if there was tenderness, it would be indicating a cartilage penetration, perichondritis. Perichondritis of
Cartilage?
no, perichondritis of the thyroid cartilage.
Okay. What are the symptoms a patient will have if there's thyroid cartilage penetration?
Painful swallowing.
Painful swallowing, number one. On examination, what will you find?
Over the neck, sir, or
Yes. Sir is
Why?
asking over the neck, what will happen if there is a thyroid cartilage is involved? What will happen? On the neck finding, inspection finding, what will happen?
widening of the neck.
Widening of the
Widening
neck.
Neck. How the
Flat
wide
neck.
neck?
There are certain specific words for that.
What is a normal thyroid angle?
120 and 90.
Okay.
So what will
So what is
happen?
it? What is that word? What is that word called? When the malignancy involve the thyroid cartilage, what will happen?
Splaying of
Yeah,
splaying.
tell that. You know it, you tell boldly. Splaying of thyroid cartilage.
splaying of thyroid cartilage.
Then you get fullness of the which membrane? Fullness over.
Cricothyroid.
Thyroid, cricothyroid, you can get fullness. Then you can get tenderness. All these things indicate that the tumor has spread beyond the larynx.
That means it is what? T?
It's T4.
T4. Okay. Okay.
T4, which one? T4?
A or B?
Thyroid cartilage involvement is?
T4A.
Then what is T4B?
Okay.
In laryngeal malignancy.
Prevertebral space and mediastinum.
Mediastinum, prevertebral, and one more. Huh?
Carotid sheath involvement.
Yeah. Carotid sheath. Okay. Why did you percuss over the manubrium?
Why did you percuss?
To know if to know whether there is any dullness of percussion, because if
there is a dullness, what will you think of?
Again, there is the tumor has extended into the mediastinum.
Tumor is extended.
The lesion is extended to the mediastinum.
Or can you get mediastinal lymph nodes?
Yes, sir, I can.
Which level is that if you get mediastinal lymph nodes?
Level of lymph nodes, sir.
Yeah, level. What level will it be?
Level 7.
Level 7. Level 7. Okay.
Yes, sir. Yes.
Okay. All right. Go ahead.
Now you summarize the case and tell the diagnosis now.
Nose and ear. Should I read through
No,
the
no.
nose and
You summarize the case and tell the diagnosis.
Summary: 72-year-old male, known case of systemic hypertension, complaints of change in voice for 2 months. On indirect laryngoscopy, matured minimal spooling in the right PFS and an ulceroproliferative growth in the posterior 1/3 of right vocal cord with irregular surface and margins. Bilateral vocal cord mobility was normal. Provisional diagnosis: glottic malignancy, and TNM staging will be T1 N0 M0.
So is it common to get a malignancy in the posterior? That normally malignancy, laryngeal malignancy is common which side of the vocal cord? Is it posterior 1/3 or anterior 2/3?
It's in the anterior 2/3.
Any other differential diagnosis you can offer? Posterior lesion. Vocal cord is mobile.
Tuberculosis.
What are the signs of TB larynx?
Hyperemia of the vocal cords, mouth nibble appearance, then interarachnoid mammaliations, turban epiglottis, ulcerations present over the vocal cords.
What is the earliest sign of TB larynx?
Weakness of voice.
Adduction weakness. Okay.
Adduction. Yes, sir.
Then marked pallor of the mucosa will be there. Okay.
Yes, sir.
So think it is malignancy.
Hmm.
How will you investigate this patient?
Okay. So I'd like to. So first, we've done all the endoscopy and flexible endoscopy.
What will you do? What investigations you will do?
First, I like to have flexible endoscopy,
Flexible what endoscopy?
like nasopharyngeal laryngo endoscopy.
Will be specific. You don't tell I'll do a flexible endoscopy. It can be flexible use of endoscopy also.
Yes, sir.
Be specific. Okay.
Yes, sir.
Flexible nasopharyngeal laryngoscopy. Why do you want to do flexible nasopharyngeal laryngoscopy?
So, to know the extent of the lesion. Hello.
Yeah, you tell.
Yes, sir. To know the site of the lesion, the extent of the lesion, and to know whether it crosses the midline or not, the surface of the lesion, then it and compared to the indirect laryngoscopy, nasopharyngeal laryngoscopy gives a more gives more vision of the hidden areas of the larynx.
Hidden areas you can see very well in flexible. Direct
No,
laryngoscopy only you can see very well. Don't tell unnecessary. You tell why do you want to do a flexible nasopharyngeal laryngoscopy? One site of lesion, extent of the lesion, anything else?
cartilage, and then to take a biopsy if a port is pressed, a biopsy port through which we can take a biopsy.
Mobility of the vocal cord, assess the
Yes,
airway. You
yes,
can
sir.
document it and keep the picture. Okay,
Yes.
these are the reasons why you do a flexible nasopharyngeal laryngoscopy. Next investigation.
Next investigation is contrast enhance.
No, you tell
CT.
the basic. No, tell the basic
Basic you
investigation.
tell.
Basic investigation is X-ray neck.
Which
Yeah,
is
why do
more
you want to
important?
take X-ray? You tell X-ray neck lateral. Why do you? You can tell whatever you want, but you should tell why. Why do you want to take X-ray neck lateral view?
No, which X-ray is more important in this patient? X-ray neck or something else?
X-ray chest, X-ray spine.
Then tell why do you want to take X-ray chest?
When you look at radiology, if you're given one investigation, which will give you the maximum information, what radiological investigation do you want?
X-ray chest.
No. For your case, what investigation will you prefer? One investigation. You are allowed to take only one radiological investigation. What investigation will you do? That is the question.
Cervical spine.
Cervical spine.
No, sir is not asking X-ray. Sir is asking radiological investigation.
CCT neck, contrast enhanced CT scan of neck.
Yeah.
Which
So
is
you'll press-
better, if you're suspecting cartilage invasion, which investigation will give you more information?
MRI.
MRI, if it is cartilage. Otherwise, CCT neck would be sufficient.
Yes, sir.
Okay.
Yes, sir.
In your staging, it's T1, right? Is it
Yes.
further subdivided?
Yes, T1 is divided T1A and T1B.
So which one is this? Why did you
T1B.
just put T1?
Yes, sir. It's T1A.
Okay, now what is T1A and what is T1B?
T1A, only one vocal cord is involved, and where T1B is both the vocal cords are involved with normal mobility of vocal cord.
Okay, so this is T1A,
Yes, sir.
M0.
Yes, sir.
Is it M0? What does M0 mean? What does M0 mean?
No distant metastasis.
How did you prove that there is no distant metastasis clinically?
It is something else. M what?
X. Max.
Okay, so you want to do a biopsy. You have taken a biopsy, you have taken a CT scan, right? What
Yes,
else?
sir.
Is there anything else you want to do, or it's come as malignancy?
Yes,
What
sir.
is the commonest malignancy that you will get?
Squamous cell carcinoma.
Squamous cell carcinoma.
Yes, sir.
Why do you have squamous epithelium over the vocal cord? whereas the rest of the respiratory epithelium is ciliated columnar. Why?
Because in ciliated epithelium, there will be goblet cells, which will produce mucus. And in vocal cord, if there is a ciliated epithelium along with mucus, there will be aspiration. I don't know, sir. Sorry.
Why do you have squamous epithelium over the vocal cord when you have ciliated columnar epithelium over the rest of the respiratory tract?
I don't know.
I don't know. What is the function of the vocal cord?
Voice phonation, voice production.
So what happens during voice production?
The vocal cords.
Squamous epithelium is a tough epithelium compared to respiratory mucosa. It's usually present at sites of trauma, friction, and all that, right?
Yes, sir. Yes, sir.
You understood during phonation,
Yes,
the
sir.
movement of the vocal cord. So you need a squamous epithelium there. There's one question in the chat box. I think they wanted to know whether you would take a biopsy first or a CT scan first. They want you to guide them. What would you tell them?
So it's a very it's very.
So what will you generally? What will you do first?
Normally, we'd first take CCT and then go for biopsy.
Why?
Because clinically, what we see as T1 radiologically can be a T2 or a T3. So
If you do biopsy first, and then do CT scan, what will be the problem?
Because when we do a biopsy and then say there'll be inflammation, there'll be inflammation of the site of the lesion.
So there will be edema.
Edema, yes, sir.
That will distort your scanning picture. It's
Yes,
always
sir.
better to do the scan and then you go in for the biopsy.
Yes, sir.
What is the difference? Have you heard of a synchronous lesion? What is the difference between a synchronous lesion and a metachronous lesion?
It's a synchronous lesion. It'll be the histopathological. It'll be the same in the entire lesion.
No. You are telling. You don't know sync.
I don't know, sir.
Do you know?
No, sir.
Chrona means time.
Mm-hmm.
Are you able to tell? No. Okay, forget that. You have taken a biopsy, scanning is done, limited to the vocal cord. What do you want to do for this patient? Dr. Gauri, do you want to ask anything?
Sir, actually, Gauri sir he has had an urgent appointment, so he went to see a patient. So he asked you to continue, sir.
Oh, okay, all right, because
I called from hospital, so
okay, all right. No problem. So, what do you want to do for this patient?
After confirming the diagnosis, I would like to give my treatment options. The best when it's a T1 malignancy, the best option is radiotherapy.
You don't tell you have to tell properly. After confirmation, I will do proper counseling to the patient. I will explain the treatment options and what are the treatment options you will explain and what is the best option. Like that you have to tell.
Okay, sir. After confirming a diagnosis, I'll be talking to the patient. I'll give them the treatment options. The treatment option we give is one, either the patient can go for radiotherapy, or we can also go for surgical excision. But according to my viewpoint, radiotherapy will be best because it's only T1 staging and it will have a better prognosis.
This is a T1A lesion.
Yes, sir.
So the patient is asking you, what is the best option? So you're saying radiotherapy is one. Second is?
Yes.
Second option is? What did you say? Second option?
Cordectomy.
What cordectomy?
Laser cordectomy. Laser cordectomy, sir.
What is that called? What is TLM?
TLM.
TLM. You have to be familiar with these terms. TLM, TORS.
Transoral robotic.
Oh, so what is TLM then?
Translap. I don't know, sir. I don't know the full form of it.
What are the
Transoral-
types of
Yeah, go ahead. Go ahead, Sajila.
what are types of cordectomies? I'm asking, sir.
Yeah.
What are the types of cordectomies? Type 1, type 2, type 3, type 4, type 5.
Yes, sir.
Type
The
1 means what?
The type 1 cordectomy is subepithelial cordectomy, which is done for severe dysplasia or carcinoma in situ. Then type 2 is subligamental, which is done for T1 malignancy. Then is transmuscular, which is done for T2 N0 staging. Then the fourth one is total or complete cordectomy, which is in T1A. Then is the extended
T1A, what did you say? Which type?
total complete cordectomy, total or complete cordectomy.
No, type 1 is subepithelial. Okay. Type 2 is subligamental.
Yes, sir.
Type 3 is what?
Transmuscular.
Muscular. Okay. Type
Yes,
4
sir.
is total cordectomy.
Total cordectomy.
Total.
Yes, total
So
cordectomy.
if you have a lesion in the middle of the vocal cord,
Yes, sir.
T1A, you're going to remove the entire vocal cord?
No, sir. The entire dish.
It's T1A.
Yes, sir.
Because you're saying for T1A, you'll do a total cordectomy.
What is
Mid-vocal
T5?
cord lesion. Yeah, mid-vocal cord lesion, T1A. Would you do a total cordectomy?
Tell you know or don't know? Yes or no? Will you
No.
do or will you do?
No.
You will not do a total cordectomy.
Okay. If you know what T5, type 5. What is type 5?
Type 5 is extended cordectomy.
What is that?
Extended cordectomy, there is 5A, 5B, 5C, 5D. So
What
A is A is contralateral vocal cord.
Oh, contralateral vocal cord also you remove. Okay. So
Yes.
Sir is asking if it's in the middle, you do total. That's it. That's why Sir is asking. If it's in the middle of the vocal cord or a small lesion in the middle of the vocal cord, will you remove the entire vocal cord? That is a question Sir is asking.
What is the margin that you require? How much of normal tissue should remain with the specimen? What is the margin in vocal cord malignancy? Are you there?
I don't know, sir.
You don't know. You have to know this because you are going to advise a patient. Which one were you advising, radiotherapy or surgery?
This patient, radiotherapy or surgery? Sir was suspecting aspiration, is considering his age, 73 years old. What advice you give for this patient? No, initially we were suspecting in the video, we were suspecting aspiration, no?
Yes,
There is
sir.
pooling of saliva. So we are talking about discussing about the aspiration and other things.
Yes, sir.
So how will you go ahead with this patient? What is his age?
72.
What is the X-ray? Okay. His chest is good?
Yes, sir.
Good. Okay. So how will you go ahead? Surgery or radiotherapy?
See, when you consider treatment in early glottic lesions, T1A, T1B, and early T2 lesions, you have two options, right?
Yes, sir.
Radiotherapy versus surgery. So tell me the advantages and disadvantages of each. Then you'll be able to make up your mind. You're
What is
there?
the advantage of radiotherapy? You tell first. Then you tell what is the advantage of surgery. Hello?
These are
Yes, sir.
expected questions for this kind of case.
Yes, sir.
See,
Advantage-
aspiration is there. Is a very see 75. What treatment option? What treatment should be your first option?
Podectomy, sir.
Sure. You will aspirate more, no? Then what will happen if you aspirate? You will get pneumonia, aspiration pneumonia.
Let me go for radiotherapy, sir.
Okay.
So you tell the advantage of radiotherapy. In radiotherapy, what type of radiotherapy will you prefer? Old conventional or the new method?
IMRT.
Huh?
Immune modulated
You tell
radiotherapy.
what is that? What is the new method? What is IMRT?
IMRT. Immune modulated radiotherapy.
Immune.
Sorry, intensive. Sorry, intensive modulator radiotherapy.
Why is it called intensity modulated as opposed to conventional radiotherapy? Why is it IMRT and what is its advantage? What is the advantage of IMRT?
Wait, sir. Sorry.
Okay. You go for radiotherapy, but why in pre-epiglottic? Why pre-epiglottic space involvement we don't give radiotherapy?
Because in pre-epiglottis phase, it's mostly fat, and radiotherapy will not be as effective.
It is fat is radio resistant.
Yes, sir.
Okay.
Can you name some contraindications to radiotherapy when you would not go in for radiotherapy? Not necessarily in this case. When will you hesitate about giving radiotherapy?
Yeah, the age of the patient.
Age, not age.
I don't know, sir. Sorry.
Okay.
In cartilage involvement, if the cartilage is involved, is radiotherapy effective?
No.
Huh?
No.
What will happen if a cartilage involvement, if you give radiotherapy, what will happen?
Necrosis of the cartilage.
Yeah, tell that.
Osteoporosis
Necrosis of the cartilage. Yeah.
Hello.
of the cartilage.
Sure.
Okay, now going back, now in this case, supposing he didn't have any aspiration, he didn't have dysphagia,
Yes,
he
sir.
had a T1A lesion.
Mhm. Yes, sir.
In terms of survival outcome and in terms of voice, which is better, radiotherapy or surgery? A younger patient comes to you, he has a T1A lesion, what are you going to advise? So you have to look at two factors. One, his survival outcome, and two, his voice. What do the papers say? What do the publications say? Randomized control trials, which is better?
If it's a young patient, then surgery is better.
Surgery is better. Why?
Because
Why is surgery better? How will you convince him that surgery is better? Survival outcome is the same in both. Voice will be the same in both. But surgery is one single treatment for a short duration. Radiotherapy is a longer duration. And it can produce complications. Like, what are the complications of radiotherapy? See, these are the answers I wanted from you when I asked you that question about advantages and disadvantages. Because when you get a case like this, the first thing you should think about is the treatment option.
Yes, sir.
So what are the complications?
Complications of radiotherapy. What will happen to the skin? What will happen to the saliva? Everything you're supposed to tell, no?
There will be a saliva, there will be serostomia, there will be decrease in saliva, dryness of mouth, mucositis, and then there will be thickening of skin.
Dysphagia. Spinal cord is right behind, right?
Yes,
There are
sir.
so many complications. So that is why people, in fact, they cannot get enough people in randomized controlled trials for radiotherapy because everybody wanted surgery. So early T1A, T1B lesions, surgery is a method. All right.
Yes, sir.
So when do you go for, what about T3 lesion? Supposing this was a bigger lesion. T3 lesion. What is T3? What does T3 mean?
T3 lesion is the vocal cord will be fixed.
Or what else?
Or cartilage involvement.
No. What is there in the side of the vocal cord? What space is there?
Paraglottic
Huh?
space. Paraglottic space.
Yeah, paraglottic space involvement.
Paraglottic space, postcricoid. So what are you going to do? T3 lesion. You have taken a biopsy, you have taken CT scan, you have to, nowadays you have to put it in front of the tumor board. We have tumor board meetings regularly where we put up these cases. There'll be radiologists, there'll be medical oncologists, surgeons. So what will they advise? T3 lesions.
Surgery.
Why they won't accept? Surgery was the standard treatment till the 1980s. There was one publication which changed everything. What is that publication?
I don't know, sir.
What will happen if you remove the larynx? No, the quality of life is gone. So you want to remove the entire larynx for T3 malignancy?
No.
What is the treatment?
Partial laryngectomy.
No.
T3, no,
Understood.
that's complete.
No,
T3
that's
Have you
lesions.
heard about organ preservation? Anything? The terminology organ preservation for a glottic T3 malignancy.
Yes,
What
sir.
is that?
Surgery.
What is that?
What conversion surgeries?
Have you heard about chemo radiation?
Yes, sir.
Yeah, chemo.
CTRT, chemotherapy, radiation. That is a treatment for T3 lesions. It used to be laryngectomy, but there was a famous trial, the VA trial. Have you heard of that? Veteran Administration trial. That changed it.
Nowadays,
heard of
for
it. Okay.
T3 malignancy, there is no total laryngectomy. It is chemo.
So when
Yeah,
do you
before
do
it-
a laryngectomy? When do you do a laryngectomy? For what lesions?
T4A, T4B lesions. External laryngectomy is done.
T4A. For T4A lesions, you do a
Laryngectomy.
laryngectomy.
Yes, sir.
So in which condition would you just do a laryngectomy, and in which conditions would you want to do adjuvant radiotherapy after laryngectomy? You have a T4A lesion, you do a laryngectomy. How do you decide whether to give post-op radiotherapy? What are the criteria you're going to look at? There are certain things you're going to look at to decide after laryngectomy whether the patient needs radiotherapy, post-op radiotherapy.
ഏത് ആണ് കൂടുതൽ കളികൾ അതിനെ കുറിച്ച് അതുപോലെ മിനിമം 40
if there is extranodal invasion of the disease.
Extra, what did you say?
Extranodal invasion.
Not invasion, extra, no, ENE. What is ENE? Extranodal extension, extranodal extension. Okay, if there is extranodal extension, then what are the other things you look at to decide on adjuvant treatment?
If the margin is positive.
Margin is positive, yes. Then positive margins, close margins, extranodal extension. Then what are the other factors you will consider for adjuvant treatment? What is PNI? PNI.
No, sir.
No, perineural invasion.
Perineural invasion, yes, sir.
You've heard of it? You
Yes,
have to
sir.
know this. You have
Yes,
to
sir.
know any oncology center you go to, you have to look at all these things. How do you decide on this? How do you know whether there is perineural invasion? From the histopathology, you take out the specimen, they'll tell you.
Yes, sir.
Perineural invasion. Then what else do you look at? What is LVI? Lymphovascular invasion. There are so many criteria that you look at after laryngectomy to decide whether this patient requires radiation also. You understood?
Yes, sir.
Radiation and plus minus chemotherapy.
Yes, sir.
Do you know what are the two criteria to add chemotherapy to this after laryngectomy? There are two things you look at to decide whether the patient requires chemotherapy also in addition to radiotherapy. Extranodal extension and a positive margin. If you have these two in your specimen, you need cover by chemotherapy also. You need to know this management, okay?
Okay, sir.
T1 to T4A,
Yes, sir.
T4B. Yeah, you were saying something, Sajila?
No, sir.
No, that she has to know there's treatment. If you're giving chemotherapy, what chemotherapy regimen would you use? What chemotherapeutic drugs?
Cisplatin,
What is the dosage of cisplatin?
30 mg per meter
30
square.
mg?
30 mg per meter square, weekly once up to 6 weeks.
Where did you get this? This is in addition to radiotherapy, right? Okay, all right, forget it. So you want to do a larynge, if it is a large lesion, T4A, you want to do a laryngectomy, right? What does T4A mean? What do you mean by T4A lesion?
It penetrates, it involves the thyroid cartilage,
Okay, then?
and it also T4A, it invades the trachea and the strap muscles and the muscles of tongue.
Extrinsic or intrinsic muscles of tongue?
Extrinsic.
Huh?
Extrinsic.
Extrinsic. What are the extrinsic muscles of tongue?
Genioglossus, hyoglossus, styloglossus,
One more.
palatoglossus.
Palatable. So extrinsic muscles of tongue,
Yes, sir.
trachea. What
Yes,
about thyroid?
Yes, sir. Thyroid cartilage also.
What percentage of cases of CA larynx will involve the thyroid?
I don't know, sir.
You don't know. Okay. Will you remove the thyroid also along with the laryngectomy specimen, or would you keep the thyroid?
We remove the thyroid also, sir.
You do a total or hemi?
A total thyroidectomy.
In all cases?
ഹലോ സർ അതെ, എന്നിട്ട് ആരെങ്കിലും ഓഡിയൻസിൽ ആർക്കെങ്കിലും ക്വസ്റ്റ്യൻ ഉണ്ടെങ്കിൽ അതും കൂടെ ഒന്ന് ചോദിച്ചിട്ട് ഫിനിഷ് ചെയ്യാം.
So if the audience has any question, they can ask. Hello.
ഷിബു സർ.
Yeah, Jennifer,
Yes, sir.
I think you had a bad day today. Okay, possibly you are
Yes,
having a bad day.
Yes, sir.
I think you came grossly underprepared. You were a bit too casual at times. It's okay. And again, even when tips were given to you by your own teachers, you didn't take that. For example, Dr. Raji was desperately trying to make you tell reasons for fixed vocal cord. He just kept on telling what the nerve and muscle, and still you couldn't catch up. Possibly it's a bad day. Okay. Now this is not just for you. I know you are feeling bad now. So this is not for you. This is for the audience. Pages in the audience. Okay. Just take your slides back to the history. Right to the history. Yeah. We found, yeah. This. Just the first slide. Yeah. Okay. See, with the history, I think this was already mentioned. With the history, you told your diagnosis is malignancy glottis, isn't it? This is what you told.
Yes,
But
sir.
just think about this history. With this history, what you have a patient who is a non-smoker who has hoarseness of voice for just 2 months. There is no way you are going to make a diagnosis of malignancy glottis unless you give some points in favor of your diagnosis. Okay. So you have to, at least you modify your history accordingly. And again, you have to be specific. You have spent so little time on hoarseness of voice, which is a main complaint. Just look at that hoarseness of voice. It is so less explained that you are unable to substantiate your claim that it is a malignancy larynx. Okay. So that is a point about history. And then just go further. No, just before this. I'm sorry, just before that. First slide. You have written no, what is it? No ear bar, no symptoms. What ear and no symptoms are you specifically asking for?
Yeah, pain.
Earache, okay. Ultimately earache. So you should mention that, okay. There is no history of earache. Why? Because of the referred otalgia. I hope you understood that.
Yes.
Then when you go to the personal history, you told the patient is a non-smoker. Okay. If you are ultimately you have made a diagnosis of malignancy larynx, always mention about passive smoking as well. Even if he's a non-smoker, always make a mention about passive smoking. Ultimately, if you have made a diagnosis of malignancy larynx. Okay. And then just take your general examination slide. Yeah, in general examination slide, your history is, your presenting complaint is change of voice. Okay. So that means in general examination, you should specifically say what is the change of voice like, because that's the first time you're going to hear the patient. When you're examining the patient, you say whether the change of voice is hoarseness or any other type of change of voice, because the examiners will discuss about hot potato voice, whatever it is. So what you should say is, this is a 72-year or 60-year-old man who has apparent hoarseness of voice. And then you mention whether there is stridor or not. Okay. That is a general examination.
Yes.
Then can you just take the indirect laryngoscopy, IL findings? Yeah, indirect laryngoscopy findings. See, when you are This is a case of malignancy larynx. Yeah, this slide. See, you are describing the larynx. Even before your larynx is over, you have jumped onto the hypopharynx. Just look at that. You have written vallicula, median lateral glossoepiglottic folds, and then you start on epiglottis, aryepiglottic folds, arytenoids, and then you immediately went to the pyriform sinus. You finish off the larynx because your main finding is in the larynx. It's a vocal cord, and then you go to the pyriform sinus. Get the point? Or go to the laryngopharynx. So you finish off the main finding first, and then go to the pyriform sinus. Okay. And then again, you should mention about mobility, which the examiners has mentioned. Okay. Always again mention about the glottic space as well. When there's a lesion on the vocal cord, mention about the glottic space, which you have not mentioned. Okay. And then you told it is an ulceroproliferative growth there on the vocal cord. As far as I can see, I could see on the limited video which you have shown, there is no ulceration. It is just a proliferative growth. And I'm not very sure. You got the biopsy already? You got the biopsy report?
Yes, sir.
Is it a malignancy?
Yes, sir.
Okay, right. And then just take the neck examination there. The neck examination should come immediately after. Okay, immediately after your entire laryngoscopy. Okay, okay, right. There, neck examination, when you're palpating, always say first finding should be, first palpation should be laryngeal framework, even before laryngeal crepitus. Okay, just say whether there is a widening of laryngeal framework, whether there is any erosion, whether there is a tenderness, everything about laryngeal framework. Then only go for laryngeal crepitus. Okay. Okay, this is not for you. I know you already know you have slightly messed it up. Okay, this is just for the postgraduates who are watching. Okay, I think possibly you have a bad day. That's all. Okay.
Thank you, sir, for your comments. Suresh, sir.
Yeah, Reggie, me?
Yeah.
Oh, okay.
So we
No,
have another only 10 minutes, sir.
Oh, okay. No problem. No, the history, you need to spend a little bit more time in a more detailed history and examination, the method of examination, as well as the order of examination, as was already pointed out to. And when you have a case like a carcinoma of the larynx, you should be ready with facts. One thing is, I don't think you're reading the journals. From what I can understand, you're not going into the journals, the veteran study, then the RCOT, this thing, RGOT trial and all that will bring out, if you go into the history of why we have reached T3 is CTRT and T4A is laryngectomy. That's a very important point.
Yes, sir. Yes, sir.
Yeah, that management in terms of radiology, in terms of surgery and all that, you need to brush up a little bit more, okay?
Yes, sir. Yes, sir.
Yeah, a little bit more reading is required. And I tell all postgraduates, at least try to read one article per day from a journal. You need to be up to date. These things change quite frequently. And then I think there was one more question here regarding margins, is it? What is considered close margin in millimeters? See, it differs depending upon the location. If it is going to be oral malignancies, anything more than 5 mm is considered a free margin. 1 to 5 millimeters is a close margin. 1 millimeter or on the tumor is a positive margin. But when you look into the larynx, you're not going to get that much of space to get a free margin. So they say even 1 millimeter is all right. Okay, but when the most important thing is when you take a biopsy, or not a biopsy, when you excise a lesion, you have to be able to tell the pathologist that this is anterior, this, you have to orient it properly so that they get the margins correct. Okay, so other than that, I don't have anything else, Reggie. You can wind up.
Yes, sir. Anuraj,
Yes, sir. Yes, sir.
can we
Yes.
conclude?
Yes, sir. Yes, sir. Sure.
Any other question from the audience, from the postgraduates? So we can conclude the session. On behalf of the organizing team, I thank Dr. Gauri Shankar for his inputs, and also I thank Dr. Suresh Pillai sir and Dr. Shibu sir for your comments and for your for your guidance, and for the postgraduates, as sir told, reading a journal is very important, and you have to get updated with the latest thing. Then only you can face the exam without any fear. Without reading, you can't face the exam. So all of you read well. So we'll conclude it. Thank you.
All right. Thank you. Thank you, Reggie.
Thank you, sir.
Okay, thank you, sir.
Thank you, Sajal. Thank you, Reggie. Good night.
Good night.